Hey guys, it's Dr. Kian. We're going to be doing an interview with Dr. Sarmela Sunder, so let me go ahead and grab her here. So, hey guys, thanks for joining. I'm just waiting for Dr. Sunder to jump on, and we're going to have a nice chat and talk about a few different things. First, an update on COVID and how it's kind of experienced affected our practices. Let's see, waiting for...
Hi.
Hey, there she is.
We made it work.
Awesome. Yeah, this is my first time doing this, so I'm glad to finally be able to figure it out.
I'm honored to be able to do this with you as your first guest.
Yeah, actually, we're going to do one every day, so I'm super excited that you're our very first one, and thought that we would kick it off here and chat. So how have you been doing?
Good. Trying to, my kids are distance learning, so trying to juggle that with work stuff's been quite interesting.
Yeah, for sure. Did they have little packets to pick up from school and whatnot?
It's so funny. It's so different now than when we were kids. So they brought home their laptops. They were given laptops, and so everything's online. They have Google Classroom and Zoom meetings and whatnot. So yeah, I should have probably had them teach me how to log into this Instagram live with you. They would have probably known better than I would have.
Awesome. Well, I'm gonna, just ask you some questions here, and then we'll just chat. So first of all, how has all this kind of COVID, coronavirus affected you, your family, and your practice?
Yeah, so obviously it's a really scary and challenging time for everyone, for patients, for staff, for the family. And I think we're just doing our best to really be there for one another. And I think each day gets a little bit scarier. And I think just kind of having some sort of plan and in mind for what are we going to do next week if X happens or if Y happens, I think that's been helpful.
Yeah. What made you finally decide to close your practice?
When there was mounting evidence that just distancing ourselves from one another is really going to, help with the older generation who seem to be much more vulnerable. When we saw that, we just felt like it would be the morally responsible thing to do to kind of shut down and eliminate people coming in and out of the office. And then, the CDC announced today that there's a significant portion of patients our age, and under the age of 55 who are ending up hospitalized. So that's really concerning. And I think it's really important that younger people, even people in their 20s and 30s, really need to be careful with this virus.
Totally, yeah. And I totally agree with you. And we've all been doing the same, just with distancing and doing as much as we can from home. And hopefully we can all get through this together. So, you were actually one of my premier faculty for a big congress that was supposed to happen next week. And it was a meeting of all the top doctors and surgeons from around the country here in Beverly Hills. It was supposed to happen next week. And you were going to be talking on stem cells and on fat grafting. So I kind of just wanted to kind of pick your brain, since you're one of the authorities on the subject, on how fat grafting plays in your practice. Who do you offer it to? Why would you pick fat grafting over fillers? And maybe kind of go from there.
Yeah, sounds good. First of all, obviously we were all really disappointed that we had to postpone that meeting, but kudos to you for being one of the leaders in having the foresight and deciding to postpone that meeting. So thank you for doing that, especially since we know how much effort you put into that meeting. It's a great meeting, and we're really looking forward to it when it comes back in August. With respect to fat grafting, that's something I do a lot of in my practice, and I really love, and I think it's completely changed the way I've treated patients over the past 5 years. So when I first came out of training, I did a lot of what were called mid-facelifts. I trained with someone who was doing, tons of them every week. And so basically a mid-facelift is to I'm not going to touch my face, but basically to lift like the sagging cheeks. And so that was a surgery that involved significant downtime. There was a lot of swelling. There was some distortion of the eyes. And so patients would recover for, 3 to 6 weeks before they look normal. And the benefit was quite subtle, so even though the mid-face was lifted, it was quite subtle. And so, I was always looking for a better option to augment the mid-face. And so that's when I started doing more of the fat transfer. And I used it as a supplement for people that wanted more cheek volume. And so obviously we have fillers that can do that. But the primary differential in my practice is if someone is needing to do fillers, twice a year or even every year for the cheek, it can get costly over time. And some people just don't want to come back in every so often and get poked with a needle over and over again. So for patients that want a longer lasting result, I think fat transfer is a great option.
So I have a question for you. So like I get usually like 1 or 2 syringes of filler maybe once a year just for my cheek and my mid-face. So if I were your patient, when would you guide me towards fat transfer over just like, 1 or 2 syringes of filler? And a lot of times like I'm wondering, well, is it going to last? Is it permanent? So what do you tell your patients?
So what I really tell patients is the way I think about fat transfer is that it's semi-permanent. So, it is a living, it's a living thing. Fat's a living thing. We're literally taking it from one area, usually from the abdomen, hips, or thighs, and putting it in the face and wanting it to survive there. Now, I don't think my fat take, and what I mean by fat take is if I transfer, let's say, a cup of fat from one area to the face, I'm not going to get 1 whole cup that survives. I might only get half a cup that survives or 3/4 of a cup. And there are a lot of different factors that come into play as to, that dictate how well that fat survives. So that's why I say semi-permanent, because not all that fat is going to survive. And then the face is such a mobile area. So when we take fat and move it to the breast, you have to be delicate with it in that you don't want to put pressure on it. You don't want to stress it in any way. But on the face, because you're constantly moving, I find that fat take in the face is not as great as in, let's say, the breast or the buttocks. So I always tell people, you kind of have to keep that in mind. So it's not going to be, I don't want people to think of it as permanent as in it's going to last 50 years, but it's definitely longer than filler for most people. So I tell people, think about it as like a 5-year filler, and a lot of people get more than 5 years with it.
Awesome. Let's talk a little bit about chins and jaw lines, because I'm sure in your practice, like in mine, tons of patients have been coming to me about like jawline and about chins. And so I used to just offer either kind of fillers to the chin or silicone implants. But recently I've been offering fat grafting for the chin, and I want to know your thoughts and experience on that.
So I actually really love fat for the chin. I don't love fat for the jawline, and I'll kind of talk about why. So
when you mean jawline, you're talking like back here?
Yeah, this area. Yeah, versus
okay.
Chin right here. And so the reason I started doing fat to the chin is I usually add fat to my facelift patients. So when I'm doing a facelift, we'll throw some fat in the cheeks, and then if I had some left over, I would add some in the chin, because that always makes the face look more chiseled and gives the appearance of a stronger jawline. So I started doing that, and then, as you know, Kian, there's stem cells, or there's controversy as to what to call it, but there's something in the fat that improves skin quality as well, and we've seen this over years and years of doing fat grafting. And so the chin area and the area around the mouth can be quite wrinkled and can get some dimpling. So I saw that as a benefit. You got this volume from the fat, but you also rejuvenated the skin of the chin and around the mouth, which is like an added bonus for the patient. So I think it's a great idea to do in the chin. People don't tend to move the chin too much, so I find that the fat tends to survive there a lot better than many other areas on the face. So I love it for the chin.
Awesome.
For the jawline, I don't love it as much because I think it can make the jawline look a little fluffy or pudgy, whereas you want the jawline to be pretty sleek and well defined. So at least in my hands, I find that it's not an ideal product in the jawline.
Got it. So let me ask you this, because you're talking a little bit about fat survivability, and we've all seen and read reports of platelet-rich plasma, or PRP, or platelet-rich fibrin, PRF, being added to fat before it's injected into the face or into the body. Do you do any of that, and what is kind of your approach to all that?
So I do add PRP to fat, especially when I'm doing nano fat. And so just to clarify what nano fat is, there's microfat that I add to the face that is more for volume. So it's fat that we take from the abdomen, let's say, and then we either centrifuge it or strain it and then take the, the fat clumps and then inject it into the face for volume. Then there's nano fat, which we take the fat and then we pass it through smaller and smaller channels until the fat basically becomes like a liquid form. And that I mix with PRP, and that I use more for skin rejuvenation, for fine lines, for wrinkles, for acne scars, things like that. And I know you're an expert in PRF, so I'd love to get your thoughts on PRF and mixing it with fat.
Yeah, so I think it's great to add PRP or PRF or some kind of plasma. It makes a lot of sense because the fat is a live cell. We take it from one part of the body, usually the belly or the flanks or somewhere else. Then we implant it into another part of the body, and we have to allow those fat cells to get blood supply and connections. And I love the concept of platelets facilitating that, because those platelets, as we know, are full of wonderful growth factors and factors that elicit the immune response. I've been using PRF for the past 3 or 4 years instead of PRP because I really like the fact that PRF gels when you inject it into the face or when you add it to tissue. So to me, it makes a lot more sense to have a gel around all of those fat cells that are going to slowly release their growth factors. They did a couple of studies in rats. They were, reasonable studies, actually comparing fat with PRF compared to fat with PRP. They did find slightly higher take rates or rates of permanent fat survival in the PRF group. But obviously, more studies need to be done to really kind of come out saying like you should be doing PRF instead of PRP. But I definitely think that adding some type of booster, plasma booster, whether it be PRP or PRF, is awesome for outcomes. So I have another question for you, and I get this all the time. So what is the average cost for a fat transfer? So let's say someone comes to you and they have some hollows under their eyes, their cheeks, temples. Let's call it a full face fat transfer. Because I have some patients coming and say, hey, what do you think for full facial rejuvenation? Sometimes I'll recommend 6, 7, 8, even 10 syringes of filler for a patient. And that's kind of when I'll start to talk to them about fat transfer because of the cost-benefit ratio of doing all that filler. So what's your approach to that patient, and what is kind of the range of prices that one would expect to pay a doctor like you or me?
So I would say in general, again, it depends on the patient. It depends on how much volume loss someone has and the areas that someone needs the fat. And then there's a combination of whether they need only microfat or if they need a combination of microfat and nanofat. So that all plays a role in it. But I would say the general range is anywhere from $5,000 to $7,500. So if you compare that to filler, where, if someone's looking at, 7, 8, 10 syringes of filler, that's going to end up being a lot more than, the fat grafting price, and they're getting a longer lasting result with the fat transfer.
I think that's perfect. And that's exactly the price range that I quote my patients as well. One of the things that I've been struggling with, and maybe you can kind of share with me what you do, is whether or not the patients need to undergo any type of anesthesia with this procedure? I mean, can you do this just under local in the office, or do you take patients to the operating room and do it under some kind of anesthesia?
So this is definitely something that can be performed under local anesthesia. We have a OR in our office, so we just do it in the OR. But a lot of patients do it under local anesthesia within our OR setting. I prefer to do it in the OR setting because it's much more sterile than any of my exam rooms. So for sterility reasons, I prefer to do it in the OR, but it can definitely be done under local, and that's how a lot of patients prefer to do it, is under local. We usually give them like a Valium just to, take the edge off.
Sure.
And if someone needs pain medication, we can do that as well. But it's really well tolerated.
Awesome. And I'm just going to kind of wrap up and ask maybe one or two more questions. So can you tell who's going to have better take rates of fat? And do you tell your patients to adhere to any type of diet or lifestyle, what to avoid or what to do afterwards to maximize the take rates of fat?
So one thing that I do recommend is I want patients to minimize movement of the face. And that's for about 2 weeks, where I don't want them to, talk excessively or move their face excessively, just kind of be guarded in their movement. So for example, when, we do a fat transfer to the breast or to the buttocks, we tell patients to keep pressure off of those areas. So similar to that, you don't want any pressure and you don't want any movement. So that's the main thing. I also tell patients that I don't want them to try to gain weight so that I have enough fat to use during the surgery, because you gain weight, I get a certain amount of fat, and then you go back down to your baseline weight, and you're going to lose a lot of that transferred fat. So an ideal situation for me would be for the patient to be at their baseline weight before fat transfer. I know some people I've heard that some physicians want their patients to lose weight before. I've heard some physicians say gain weight before, but for me, I just want you to be at your ideal weight so that I know what I'm working with. And I know some doctors do recommend kind of doing a high carb diet in the post-op period. I'm fine with that. I think it may help. I don't think there's any clear evidence saying that it does help, but my patients love having an excuse to carb load during the recovery period. So I'm fine with that.
Yeah, that's great. That's similar to what we do. If patients are on keto, I make them come off keto because I don't want my patient in a catabolic state while performing this. I also recommend they go on an anti-inflammatory diet and minimize their sugar intake. And all the different factors that I think will help survival of the fat. I've had a few patients ask me about hyperbaric oxygen therapy and whether they should immerse in a tank and have hypervascularity. There hasn't been enough evidence for me to make it part of the protocol because it does come at an extra cost, and I'm frankly personally terrified of being in a tank for several hours, a little bit of claustrophobia. So if I'm going to recommend that to somebody, there better be some good science behind it. So did you want to talk about anything else with regards to fat grafting or anything else?
No, I mean, the most common question I get about fat grafting, other than the ones that we've already gone through, is, combination procedures with it or adjunctive procedures with it. And I think for me, I think it's a great adjunct to a facelift, but it's also a great adjunct to like a resurfacing procedure. Because I think, like we talked about, it improves skin quality. So, and I find that it really improves the healing time in a lot of ways by cutting it down by a few days. So I find that the fat is beneficial on its own, but it can actually help with the laser results as well. So those are the top 2 procedures that I kind of combine it with. Awesome.
Actually, Sarmela, a lot of really great questions came through, and one just came up that I think is important because I kind of want to know how you handle this.
Sure.
The question is, if the fat doesn't take on one side, then what do you do? Or do you encounter that a lot? And I get this often, like, well, will the fat take on one side and not the other? And if it is uneven or doesn't take, what is your approach? Do you add more fat or do you just add filler in that circumstance?
Yeah, so I don't think I've had a situation where one side completely didn't take and the other side did, but there are definitely like pockets where it doesn't take as well as other areas. So in that scenario, if I think the patient's able to retain fat and it's not an issue with that, then I would offer to re-inject the fat. But if it seems like there's some systemic issue at play where I think redoing the fat is not going to work again, then I would supplement with filler. But
So,
we take it on an individual basis. But I do, there are certain patients that I guide and say you may need 2 or 3 sessions of this to get to your target, end goal.
totally. And I tell patients the same. I say this is going to get you about 80% of what you want to get. And the other 20%, whether we decide to do fillers or do another round. And all of you that are watching this either live or later, I would say to go to Dr. Sunder's page or YouTube or go to mine. The technique for fat grafting is very different than with fillers. We're moving a lot and we're injecting tiny little amounts of fat because we want them to be very small particles of fat so that the body can surround it and take it up with new blood vessels. So that's why it's not like one cheek will take and one won't. That's just impossible with good technique. Now, if you were to inject a big blob of fat into someone's face, then yeah, a lot of that potentially wouldn't survive. But those of us that are fat grafting experts, like Dr. Sunder and myself, that's not the technique that we use. And so I would advocate that you, if you can handle watching those types of videos, you go to our pages to see that the technique, because it is very different than fillers, which is why you get a lot more swelling, but that swelling lasts about a week or so.
Absolutely.
Awesome. Well, Dr. Sunder, thank you so much for joining me. We're all trying to find out what to do with our time, neighborhood consults, virtual consults, and these chats. I'm going to be doing these chats every day with a different expert in the field. And I really hope that you, your family, your staff and your practice are all really safe and well. And I'm looking forward to all of us getting through this crazy time.
Absolutely. Same to you. Thank you again for having me on. And I'm really looking forward to the meeting in August.
Awesome. We'll see you then. Okay.
See you then. Bye.